Low back pain presented by Nadhi and Antar. Low back pain, LBP, describes pain between the lower edge of the ribs and the buttocks. It can be a dull ache or a sharp pain. It can also cause pain to radiate into other areas of the body, especially the legs. LBP makes movement harder and can affect the quality of life and mental well-being. This limits the work activities and the engagement with family and friends. Other associated effects include sleeping problems, low mood and distress. It can last for a short time, acute, under 6 weeks, a little longer, subacute 6 to 12 weeks, or a long time, chronic, over 12 weeks. It can be classified into specific and non-specific low back pain. Specific LBP is pain that is caused by a certain disease or structural problem in the spine, or when the pain radiates from another part of the body. Non-specific LBP is when it isn't possible to identify a specific disease or structural reason to explain the pain. LBP is non-specific in about 90% of cases.
Now let's explore the mechanisms of chronic low back pain. For decades, back pain was viewed simply as a structural issue, a mechanical fault in the spine. However, modern science shows us it is far more complex. It is a biopsychosocial phenomenon. Transitioning from acute to chronic pain involves significant neuroplasticity, meaning the pain experience is actively maintained and amplified by an interaction between peripheral tissues, the central nervous system, and a patient's cognitive state. The initial trigger for many patients is nociceptive. This is the structural, mechanical pain most people envision, originating from worn-out discs, strained facet joints, or torn fascia. When these tissues break down, they directly stimulate local pain receptors. Crucially, this tissue damage releases biochemicals that initiate a localized inflammatory cascade, setting the stage for more complex neurological changes. As inflammation persists, the peripheral nervous system becomes overly sensitive. The threshold for pain receptors to fire drops dramatically. Pathologically, we even see sensory nerves growing into the damaged disc space. Furthermore, inflamed dorsal root ganglia can begin firing spontaneous pain signals, known as ectopic discharges. This explains why some patients experience severe shooting radicular pain down their leg, even when an MRI shows no physical nerve compression. This constant bombardment of pain signals eventually alters the central nervous system. Chronic peripheral signaling activates glial cells in the brain, driving neuroinflammation. The central nervous system essentially turns up the volume on sensory input, a process called central sensitization. Simultaneously, connectivity between the prefrontal cortex and the periaqueductal gray diminishes, meaning the brain loses its natural ability to send descending signals to inhibit or block the pain. From a neuropsychological perspective, chronic pain literally reshapes the brain. We observe reduced gray matter volume, actual tissue atrophy, in regions like the dorsolateral prefrontal cortex. These morphological changes share mechanisms with neurodegenerative disorders, contributing to cognitive fatigue or brain fog. Furthermore, the brain's internal map of the back becomes smudged. As this cortical mapping blurs, patients lose tactile acuity and the ability to accurately coordinate their back muscles. Finally, the patient's psychological state acts as a direct mechanism of pain maintenance. Negative expectations and distress, termed the Drucebo effect, biochemically worsen symptoms and reduce treatment efficacy. Pain catastrophizing and kinesiophobia, which is the fear of movement, strongly reinforce central sensitization. Reconceptualizing the threat value of pain through pain neuroscience education can actually alter these neural pathways and downregulate the nervous system. Assessing these mechanisms requires focusing on specific pain generators rather than jumping to early MRI scans, which often correlate poorly with actual pain. We utilize validated scales to measure tissue and nerve pain separately. Crucially, because of central sensitization and cognitive factors, a modern assessment must include sensory testing, like checking pressure pain thresholds or tactile acuity on the skin, alongside psychological screening for fear avoidance behaviors. Because the mechanisms are multifaceted, treatment must be multidisciplinary. Active physical rehabilitation, specifically lumbar stabilization and neural flossing, is foundational. This is paired with cognitive and behavioral therapies like CBT to actively reduce fear and down-regulate the nervous system. Manual therapies can help restore local joint mobility, whilst pharmacological and minimally invasive interventional procedures are held in reserve for severe cases that do not respond to conservative biopsychosocial care. Thank you.